Hello, thanks for coming to today's video where we're going to be discussing lymphoblastic leukemia. So in order to start discussing lymphoblastic leukemia, we kind of need to go over the differentiation of the B cells and T cells. Here we only have the B cells, and T cells are very similar, so I didn't really feel like we needed to have a whole other diagram here. But as you can see, it goes from pro-B to pre-B to B cell, and then B cell will continue on to become a plasma cell, which is the one responsible for releasing immunoglobulins. Now, when we have leukemias, what will happen is, as it's progressing through these stages, somewhere along the way, it'll have some sort of mutation for whatever reason, either some type of drug, something in the environment, something will cause a certain type of mutation along the way, and it'll prevent it from continuing on to the next stage. And once that happens, you have what's called a clonal expansion of a progenitor. So clonal meaning a single type of cell, and these are all progenitors to, these two here are progenitors to B cell, and B cell, I guess you can say, is a progenitor to a plasma cell. So somewhere along the way, you're going to have a problem here. Now, when it comes to CLL, which is chronic lymphocytic leukemia, here the problem will occur after it has become a B cell, and it's going so after it becomes a B cell and before it becomes a plasma cell. So what will happen is you're going to have an accumulation of B cells, and obviously there will be no plasma cells and therefore no immunoglobulin. So you're not going to have anything to the right of this arrow, and so the biggest thing to remember is chronic lymphocytic leukemia is a problem right between B cell and plasma cell. So that's chronic lymphocytic leukemia. The other type of leukemia is going to be acute lymphocytic leukemia, which is all of these. So all of the pro, pre, and B is going to be acute lymphocytic leukemia. The most common one being, so basically when in here you can have a problem either between pro and pre, and between pre and actual B cell. Generally, acute lymphocytic leukemia will not affect this area here where CLL is primarily affected. Which one is the most common? The most common will be B cell. And actually, real quick, I'm saying B cells here, but of course, acute lymphocytic leukemia can also affect T cells. So it is important to kind of remember that. Whereas CLL does not affect T cells, it only affects B cells. So that's a quick thing to remember. And again, which one is the most common? 85% of the time, we're going to have pro-B cell. So now that we've kind of talked about pathogenesis, the next thing we can talk about is each of those individually, right? So we're going to put acute lymphoblastic leukemia on the left side here, or acute lymphocytic leukemia as well, and then we can put chronic lymphocytic leukemia on the right side here. So acute lymphocytic leukemia generally happens in children less than 15 years old, peaking anywhere between 2 and 5 years. Now, it can occur in adults, and when it does, that's generally a very poor prognosis. So not common, but when it does, it's pretty poor. Chronic lymphocytic leukemia, also known as CLL, is the exact opposite. It's found in the elderly greater than 60 years old, and it peaks at around the age of 65. So you can see a big distinguishing feature between the two. Now, there are some risk factors related to acute lymphocytic leukemia. We'll go over that. First, there's drugs such as antineoplastic drugs and even benzene. And on top of that, sometimes radiation, either exposure for whatever reason, they can get that. There are some other cancers such as Hodgkin's lymphoma and multiple myeloma, which can kind of predilect for acute lymphocytic leukemia. And finally, some conditions such as Down syndrome, Wiskott-Aldrich syndrome, and even ataxia telangiectasia. So that's kind of a brief introduction to epidemiology and etiology there. So now what we'll do is we'll talk about, go more to the pathophysiology. So acute lymphocytic leukemia blocks at an early age, either pro-B cell, pre-B cell, or B cell, and it can even affect T cell. And 85% are pro-B cell. So we've kind of already talked about that, and we've already talked about how chronic lymphocytic leukemia blocks the virgin B cell. The virgin B cell being the B cell that's right before it becomes a plasma cell. And therefore, there's going to be no immunoglobulin. So that's going to be the general pathology. Now, pathophysiology, what will tend to happen is once you have this blockage, there will tend to be accumulation in the bone marrow. until the point that these progenitor cells completely replace the bone marrow. And after a while, it'll push all the normal progenitor cells out, and you'll eventually have bone marrow failure. Eventually, when there's no space in the bone marrow, it'll go into peripheral blood, causing leukocytosis, and then metastasis, either to the CNS or to the testes, which is most common for both of them. So this is the general pathophysiology here. What we can now just kind of push our attention to is the clinical aspect. So we'll talk about clinical here. So ALL starts abruptly, whereas CLL is very insidious, oftentimes found on an incidental CBC, or it might be seen as a painful lymph node. So sometimes you get this lymph node that's pretty painful. Now, the symptoms, there are some symptoms that are related to both of them, and there's some symptoms that are unique. So what we'll do is I'll first go over the symptoms that are related to both of them. Now, as you know, both of them have bone marrow failure, and so there's symptoms related simply to that. The first being anemia, second being thrombocytopenia, and there's going to be leukocytosis rather than leukopenia, but what I'll write is decreased immunity, because even though you have a lot of lymphocytes, they're not working. So overall, you're going to have decreased immunity. Now, anemia. What is symptom from anemia? This can be fatigue or pallor. Thrombocytopenia, obviously, you're going to have constant bleeding, and decreased immunity leads to fevers and constant infection. So that's going to be decreased immunity. Now, the other symptoms that's related to both are going to be related to the fact of the metastasis. So this can be hepatosplenomegaly. Not only that, you can also get lymphadenopathy. If it invades this, it can also invade the CNS and testes. So if it invades the CNS, you get headache, nuclear rigidity, and even papilledema if there's increased intracranial pressure. And if it does get to testes, it's going to be painless enlargement of the testes. So that's one differential to think about when you do have that. So these are the symptoms that are related to both of them. Now what we'll do is we'll kind of talk about some of the symptoms that's related either to one or the other. The first that we can talk about in ALL is bone pain. And this bone pain is related to expansion of the bone marrow, which leads to kind of tenderness and a form of arthritis. And this may present as limping, and oftentimes this might be the only symptom. And since it's such a vague symptom, and you don't really think, oh, someone's limping, it might be leukemia. Sometimes you can delay the diagnosis, so that's something to think of. Next, you can also get a mediastinal mass, and this is only found in T cells, and this just because enlargement of the thymus. And this generally shows up on X-ray. You can see it on the X-ray, and it can actually be so severe that it might lead to respiratory distress or even stridor. So those are the two symptoms that can come up on that. With chronic lymphocytic leukemia, there are some autoimmune conditions that it can result. This can either be cold agglutinins such as IgG or warm agglutinins such as IgM, and this can cause autoimmune hemolytic anemia. Pemphigus has been associated with it, ITP has been associated with it, and even they could be Crohn's positive, which is the autoimmune hemolytic anemia. And finally, you can even get some neuropathy as well. Another interesting symptom here, or not a symptom, but a transformation, is called Richter's transformation. And this is basically, it turns into a very aggressive form of large B-cell lymphoma with some of the B symptoms. And so what you'll see is there's going to be a sudden enlargement of the lymph node. And so whenever you have that, obviously you want to biopsy it. And along with the sudden enlargement, they're going to have the B symptom, which is malaise, fever, and night sweat. So generally when a patient does have this is a very poor prognosis. Generally means they have months to live. So not a good thing to happen, but this is something to watch out for. So next what we can do is we can go into kind of the lab workup and the general workup you want to do for a patient who you're suspecting of leukemia. So the first thing is you're going to want to do labs. For both of them, they might be 10 to 100,000 lymphocytes with a increase in lymphoblasts. Both of them will tend to have that. You can have normocytic or macrocytic anemia in both of them. Macrocytic anemia is generally caused because of the low folate, because it's producing a lot of those lymphoblasts, and so that's going to use up all the folate, and so you don't have any left over for making red blood cells, finally leading to a macrocytic anemia. Both of them will have a thrombocytopenia of sometimes less than 100,000 per millimeter cubed. And if you do a bone marrow aspiration, both of them will be hypercellular. So again, these are symptoms related to both of them. Now let's kind of become more specific. In chronic lymphocytic leukemia, not only can it be from 10 to 100,000, but it can actually reach up to 200,000. So, and there will be no immunoglobulins. So again, no immunoglobulins in chronic lymphocytic leukemia, because there's a problem with that B cell becoming a plasma cell. Also, with regards to being hypercellular, chronic lymphocytic leukemia generally has less than 10% lymphoblasts, whereas acute lymphocytic leukemia has greater than 25% lymphoblasts. And actually, what you'll generally find is that the bone marrow is completely replaced with lymphoblasts. So that's going to be kind of key thing for acute lymphocytic leukemia. There are some markers. For ALL, it's going to be TDT positive, and this is one of the markers for some of the pre-B, pre-pro B, and even the pre-pro T cell. Now, if it is a B cell, a pre-B cell, it'll also be CALLA positive or CD10 positive, and T cell will be CD10 negative. So that's a key thing to keep in mind there. With regards to CLL, you're going to have the B cell markers such as CD19, CD20, CD21, and CD23. And again, these are general B cell markers, nothing more than that. However, what's interesting is in CLL, even though it is a problem with the B cell, you get CD5 positive. And CD5 positive is interesting because that's a marker on the T cell. And so this is also known as an aberrant CD marker. And so this is one huge suggestion that you're probably dealing with a CLL. So anytime you see the CD5 on a B cell, you definitely want to think of chronic lymphocytic leukemia. What you also might want to check is do a blood smear. And on CLL, you get something very characteristic, which is called the smudge cells. So those three that I circled right there are called smudge cells, and they're formed. That's not how it looks actually in vivo. What happened is they become very weak, and so when you make the slide prep, they actually smudge on the slide prep. And so this is called smudge cells. And so again, this isn't normally found like that in the body, but it's from the actual slide prep. Now, with ALL, there is some cytogenetic features. The two major one is going to be 1221 and hyperploidy, and they have a general favorable prognosis. So we've talked about the workup. So now what we can do is we can continue on with the management. So with ALL, you're going to, the mainstay is chemotherapy, and the chemotherapy has classically had three stages. First is going to be the induction stage. Then from the induction, you go down to consolidation stage. And finally, you went to a maintenance stage. So let's go through each one, and there's been some updates, so I'll mention that as well. So this was the classical three-stage system. Induction was basically you try to get remission and remission was less than 5% blast or a normal CBC. And so in this phase, you generally used three drugs, glucocorticoids, as you know, that's immunosuppressive, vincristine, and asparaginase. So these were your three main chemotherapeutic agents during the induction phase. Then what you try to do is called consolidation, where you try to get rid of maybe some of the cells that might have been resistant to these previous three drugs. And what they found was to do that, you have to use different drugs that most likely the cells that were resistant to these three drugs will not be resistant to. So one of the points of consolidation is to prevent resistance and relapse by resistant drugs. And then you do that by changing the drug. So then you use cyclophosphamide, cytarabine, and even 6-mercaptopurine. And so these generally tend to have much more higher side effects. Again, you do have to use that to kind of clear up those last few cells that might be there. So from this, you generally move to maintenance phase, but they've actually noticed they've changed up the regimen because some studies have showed that they're better. And so the new way they do it is after consolidation, they go to an interim stage, and afterwards they go into an intensification stage. So in the interim stage, what you're trying to do is you're trying to continue giving them chemotherapeutics, but not destroying the bone marrow. So these can be drugs such as vincristine and methotrexate. They've been classically used. And so again, that's what you're trying to do. You're trying to continue the regimen so you can continue killing the cells, but at the same time, you want some of the bone marrow elements to start developing. Now, in intensification, what basically you do is you repeat the induction and consolidation. And they used to only do this with high-risk patients, but now they found it's beneficial to all patients, so now they're doing it with all patients. And finally, once you've done all that, you can go into the maintenance stage. And in maintenance, you're trying to prevent relapse and recurrence. That's your main goal. And so you do that by first doing intrathecal methotrexate, and this is because one of the problems is going to the CNS. So by giving intrathecally, you can protect the CNS, and you do this about every 3 months. And classically, they use cranial irradiation. I'm not sure if they still use it, but this was the classical thing they did. And obviously, the big side effect with that is you can get brain tumors, which will just cause more problems. And so what you also do after giving intrathecal methotrexate every 3 months, you also do weekly methotrexate. You do a daily 6 mercaptopurine, and you do a vincristine glucocorticoid pulse every 1 to 3 months. So this is kind of what you do until to make sure he doesn't relapse. Now, from the treatment, there could be a syndrome that is sometimes produced, and that's called tumor lysis syndrome. And this is produced because, and this occurs primarily in the induction stage. So the induction stage is where this occurs, and this is because you have such an increase in cell death that you increase the uric acid that's in the cells, calcium that's in the cells, and you could even decrease the calcium. And so that's because when the cells rupture, this is what's normally found at high concentrations in the cells. And so what can this do? Specifically, the uric acid becomes a big problem because this can lead to renal failure due to the crystals that are formed. So there's certain ways to prevent this. So when you're in the induction stage, first of all, of course, you want to monitor all the electrolytes in uric acid, as well as the acid and base levels. But to prevent it, what you start doing is you give them IV fluids, double the maintenance. And so this will make sure that the uric acid is soluble. Secondly, you can give sodium bicarb. This alkalinizes the urine, and so then the uric acid becomes more soluble in urine, so easier to excrete. Allopurinol, as we know, is a xanthine oxidase inhibitor, and this decreases uric acid. But here's the problem. Allopurinol only is going to work with uric acid after this point. It doesn't work with any uric acid that's already in the blood. And that's because allopurinol inhibits xanthine oxidase, which is going to be the production of new uric acid. So to take care of the uric acid that may have already been formed because of treatment, you can use something called resburicase. And this makes uric acid that's already formed more soluble and therefore easier to excrete. So that's acute lymphocytic leukemia. Now what we'll do is we'll change our mind frame into chronic lymphocytic leukemia. And so here there is a staging system that I want to go over first. 2 types, either the Ray-Sawitzky or the Bennett system. Ray-Sawitzky is used in the US, whereas Bennett system is used in Europe. So the Ray-Sawitzky and Bennett, they both have 3 stages. So in Ray-Sawitzky, you have low stage, intermediate stage, and high stage. So in low stage, you have lymphocytosis. In the intermediate stage, you add on lymphadenopathy and hepatosplenomegaly. And finally, in the high stage, you can get anemia, or you can also get thrombocytopenia. So these are your 3 stages here. Bennett is distributed with A, B, and C. So in A, you have normal, no anemia, no platelets, and you have less than 3 lymph nodes involved. Whereas in B, you have 3 lymph nodes involved, and in C, you have anemia, thrombocytopenia, and 3 lymph nodes involved. So pretty straightforward type of staging system. So how do you treat chronic lymphocytic leukemia? The problem here is, unlike with acute lymphocytic leukemia, the cells aren't dividing as rapidly, and so it's a very slow progressive course, and so these type of cells are not as responsive to chemo. And so one of the things that they've actually found is starting chemo right away oftentimes is not a good idea, because it's actually been shown to increase mortality just from the drugs alone. And so what the current recommendation is you wait until there's any signs or symptoms or anything that starts showing that the disease is progressing. Once you have that, then you start chemotherapy. So one of the main drugs that's given is going to be a nucleoside analog, and these work really well on indolent lymphoid malignancies, which just means slow-growing malignancies. And these can be any drugs such as fludarabine, cladribine, or even pentostatin. Fludarabine is the one that's the first-line use, so this has been the most popular to use. Besides this, you can use some monoclonal antibodies, such as alemtuzumab, and alemtuzumab is a CD52 blocker, and so there's tons of monoclonal antibodies that have been released. However, it's really hard to come up with a good regimen because patients are very, very elderly, and so not a lot of times can you enroll them in something, it's experimental. So even when you enroll the patients, they tend to have to be very healthy, and so since the patients in the study are very healthy, it doesn't necessarily reflect how it will act, how the drug will be on patients who might have comorbidities as elderly do. So it's a tough way to come up with a drug regimen. However, one thing that you can do is an allogeneic stem cell transplant, if the patient is able to handle something like that. And if you are able to do that, then that's going to be potentially curative. So this is just a brief or overall view of lymphoblastic leukemias. Hope you guys find that helpful. See you guys in my future videos. Bye-bye.